We're going to start this with the soft tissue injuries, and then we'll move into those burns. As always, your book gives you a nice little anatomy and physiology section at the very beginning. So this chapter is no different. It gives you the breakdown of the skin with nice diagrams and labels on all your parts and pieces. And it goes into all the layers of the skin, which are going to be important, especially in the burn section. So um, make sure that you're familiar with those and how all of that works. Soft tissue injuries, typically, we're going to be looking at two types of soft tissue injuries, mostly either open or closed injuries. So with the soft tissue, we're talking about the skin, and possibly where you're going to see some injury is going to come from some organs if it's in the abdominal region, and then if it's anywhere else, it's just going to be skin injuries. So we could have some blood vessels involved. You may see some bleeding or bruising, and that's going to be about the gist of it. So um, you guys, if you look in your book, you can see 35-2 figure. There's a contusion of the lower abdomen. Um, this would be one of those soft tissue injuries. It's a closed injury because there's no external bleeding, and then but you can see the massive size of the contusion, which basically takes up a good portion of the abdomen. So you would expect to see a lot, or expect to have a good amount of internal bleeding happening with that type of injury. So external injuries we're going to see with mostly they're going to reflect with bleeding first and foremost. There may be some other things that are present for you, but external injuries are going to first and foremost show bleeding. The closed, or those would be the open injuries, external bleeding, open injuries. The closed injuries, we're going to see patients that have a sense of pain, tenderness at the injury site, maybe edema, definitely discoloration, um, and then the signs of internal bleeding, these contusions that may show up. These folks we're going to have to monitor closely with vital signs because of, especially if the injury is in the chest or abdominal region, pelvic region, we're going to have to monitor for vital signs to see trending things that are leading us to hypoperfusion or shock. So so monitor these folks carefully and closely, and watch for those vital sign trends. If they start showing signs of compensation, blood pressures, dropping, pulse rates increasing, those types of things, we could be running into some troubles. So the closed uh, injuries could be more problematic for you than some of these open injuries. Um, Again, with the open ones, we're going to be looking at bleeding control fairly quickly. Remember that change was we're going to stop the bleed quick. So whatever you need to do, direct pressure is preferred, and if not, we'll be looking at tourniquets on the extremities. If we're in the chest abdomen region, we may be looking at occlusive dressings, depending on what kind of open it is, and then direct pressure for sure. Remember now on the bleeding control, we can pack these wounds. So you're allowed to pack things into some gauze in there to stop the bleed. So keep that in mind.
Is QuikClot an AMT skill?
It is. You guys can use QuikClot. So if you have it, you can certainly use it. And if it's in the form of the powder, it's going to be a sprinkle on kind of thing. If it's meshed into the gauze, that's going to be the type of thing that you're going to need to really pack in there and then apply some pressure to get it to go. So, but yeah, you can certainly use the QuikClot.
I just wanted that was an option.
It is. So if you have it on your trucks, it's definitely an option for you. All right. The other thing with soft tissue injuries, that the book and PowerPoints and all get into crush injuries. So with crush injuries, this could be any part of the body, or it could be one extremity. It could be both of like the lower extremities, waist down, chest down, kind of thing. Any part of the body can be crushed. If it's the head, we're probably just going to call it, but if it's anything else where the patient is still alive, then we're going to have to manage them under this crush situation. So with the crush injuries, what's the danger? What's the concern for us? And what do we need to be managing?
The airway and the wound itself, if we can. We're trying to avoid that lactic acid and all that buildup. Because
Okay.
once it circulates back with the blood and circulates back to the body, it'll drop immediately into shock and explode on you.
Okay. So certainly going to manage the airway, and we're going to manage the patient. Typically under crush situations and crush injuries, if they're still alive, then the crush is the object that's crushing them is probably actually keeping them alive because it's occluding the blood flow, keeping them from bleeding out, keeping them from circulating the toxins that are building up. So as long as the crushed object is there, then they're probably fairly stable, okay, type of thing. And when you release the pressure from the crush, that is when things are going to go terribly wrong and bad for you and them. So keep that in mind.
On the TXA, like I know the paramedics in Dare County have the ability for TXA
Yes.
and all that. But I know as advanced we can't push it or do anything with it.
Right.
But like, what's your thought on crush injuries in TXA?
Well, TXA is supposed to help stop bleeding. With the crush injury, internal bleeding, the TXA is probably not going to be effective on, but more importantly, with the crush injury, they're worried about the toxins building up, so sodium bicarb becomes a priority, which again, you're going to need the medics for it because of your ability to not give it. One of your discussions back in the medical section talked about rhabdomyolysis, how we were overworking muscles with the marathon runners and how they were working those muscles so hard that the muscle was actually breaking down and becoming releasing toxins into the bloodstream. Um, Long term, we're looking at kidney failure, and then things go south farther and faster from there. So, with the crush injury, you're going to deal with the same thing. This is going to be on the traumatic side, but with the toxins that are building up and not circulating, we're basically lining them all up at the gate. And when we release that pressure, we release the floodgates for all of those toxins to run through the system.
Would
Uh,
it would it help to, so say someone has like their arm from the elbow down crushed in something, would it be feasible to put a tourniquet above the elbow and then release it, and that would prevent the flow of the toxins from getting like in the rest of the body?
Potentially, if you've got the tourniquet on tight enough, that could be an option for you. Where it would, if it was just like part of an extremity, that's certainly an option. If it's more of like, a car that pins somebody between another car, between the two cars, or a wall in the car,
Yeah,
and
it's a bit more complicated.
we're talking about both legs and the pelvis. You can't like tie a tourniquet around their waist. So these are the problems that we're going to face. A simple extremity, one or half of one, certainly that's appropriate. You could put a tourniquet on it, probably maintain them as fairly stable. But it's when you can't do that we're going to face the music on, because at some point you have to release the pressure, and of course the longer you wait, the worse it's going to be, and the worse the crush, the more toxins you're going to release. So what they're having the medics do now is kind of load the patient up on sodium bicarb, and they'll give them an amp of that, and they'll load them up with some other things, and hopefully kind of wide open fluids, preload them with bicarb, and then as this pressure releases and that stuff starts circulating through, we'll certainly see how they react. But we should expect cardiac dysrhythmias. We should expect electrolyte imbalances. We should expect shock, and essentially get ready for the code to happen, because when that pressure is released, they'll usually bleed out if they have internal damage to that extent. So the crush injuries can be pretty traumatic and devastating, and not necessarily have a good ending. In a lot of cases, if you have the patient stable for a little bit while they're crushed, and you're trying to figure out how to get them out, or you're waiting on the fire department to do some things to get them out, if that pressure is keeping them alive from the crush, it may be a good time to think about, before releasing that pressure, it may be a good time to think about phone calls or family members for that person, because when you release that pressure, there's a high probability that they're just going to code and go away. So if at all, if it's helpful for them to make a phone call to a spouse or a child or something, or if they can get to the scene to say goodbye to them, that may be something to think about, and it may be appropriate, because they probably won't live through it. So keep those things in mind. Try to not get tunnel vision into the moment, but think more on the big picture of what's going on, and probably what the outcomes are going to become. So that's the hard part with crushes. your book gets into some pretty nasty pictures here. So as you're skimming through, there's a crush injury to the hand, pretty gruesome for the fingers. There's a degloving in there, which is extremely nasty. There's some amputated fingers. So all of these things are potential issues for you. Remember with the amputations that if you can preserve the amputated parts, please try to do so. Put them in a separate bag that's dry, but we want to keep them out of water and liquid, and we want to keep them cool. So on ice if possible, or cold packs, but not directly. So put them in a separate bag and then put cold packs around them or ice so that they can stay cool, and try to get those to go with the patient. Maybe they can reattach them, maybe they can't, but we'll at least give them the opportunity to make that decision farther down the treatment path.
So how does this degloving on page 802? I mean, how does that happen? I mean, I've never seen that before. I've seen mostly everything, but I've never seen that.
Typically, something will get caught. It'll get caught or hung. This is where jewelry is a major culprit. Rings around fingers and bracelets around wrists, things like that. If you're dealing with machineries or things, your ring could get hung on it, and before you can get it stopped, it just basically tears the skin and slides it down. So that's what the degloving is. Rings are particularly tough, so they don't break easily. And if you have those around your fingers, if you're working around machinery and different things like that, anything that moves mechanically, it's a hazard. So be careful with that. The problem with deglovings, you're going to rip layers of skin off, but more problematic would be damaging the blood vessels, the arteries, the veins, those types of things. If those get torn, ripped, broken, then you're going to deal with a lot of bleeding. And so that's going to be an issue for you. In this area, you could expect deglovings mostly probably in farm equipment. Some of those machineries, any things that have belts on them, like, on cars, the fan belts, drive belts, those types of things, if they grab it, they can rip the skin. So just a lot of moving machinery parts. As we keep going through these different injuries, we're looking at there's one of a abdominal gunshot wound. You can see that 35-8. And so this wound, how would you manage that abdominal gunshot wound?
We can put an occlusive dressing on it.
Okay, so occlusive dressing would be appropriate for it. Try to stop the bleed, keep the blood in. Obviously, we know there's going to be some internal damage because it's a gunshot. So if the bullet is still in there and there's no exit wound, Remember, if you have an entry and an exit wound, you need 2 occlusive dressings, 1 for each. But if there's no exit wound, then you know that the bullet is still in there. So all the movements that you do with this patient could cause further injury. So you want to try to limit those as much as possible. Keep the patient still. Don't roll them and shake them and throw them around any more than you need to. And then worry about all the internal bleeding that's going on. So these folks need to get to a trauma center as quick as possible and expect surgery. There's a pretty nasty picture on 35-9. It's a knife somebody's been stabbed in the shoulder with a knife. So it's kind of at the base of their neck, on the back side, at the shoulder. And there's an interesting, they took an x-ray of it. So it's got the external picture along with the x-rayed picture. So you can see that the knife has one of those little grooves in it for cutting, like it looks like kind of like seat belts or skinning a deer type of thing. But that's the problem with having these things, and this is why we don't remove these objects, because we can't see what they're next to or how much damage they're going to do when they come out. So this is that kind of thing where we would stabilize it with some gauze and keep it where it is, keep them still, and manage if there's any bleeding, bandage that, and then we're going to manage them for shock. So most of these tissue injuries, soft tissue injuries, they're going to be, they may not all be bleeding all that much. They're probably going to look kind of gruesome at first, but once you get a look at it, you can tell that if the bleeding is controlled, you'll be able to see where the injury is, laceration or avulsion or whatever it may be. But if there's a lot of bleeding, we need to control it. So that's the first priority. And then we can get a good look and see what the actual injury is, and then deal with that. All right. So, but bleeding control is going to be our thing, and then wound care is going to be a thing, and then signs and symptoms of shock is going to be the other thing. So we just need to manage them for shock. With all traumatic injuries, that's probably how we're going to look at things. We're going to manage them for shock at some point, so be expecting that. And then it's taking care of the wounds or the injuries. So remember your standard precautions when you're dealing with wound care on these soft tissue injuries. If the injuries are closed, there shouldn't be any bleeding coming out at you, but if they're open, there may be different types of bleeding coming out at you. So make sure that you're using your standard precautions and bleeding control techniques. Again, don't be afraid to go after the tourniquets. Anybody have any questions about soft tissue stuff?
Not really. Not really. It all seems kind of like I don't know. There's not much we can do aside from stop the bleeding and give him IV fluids.
Yeah, stop the bleeding, bandage the wound, do your wound care appropriately, and then manage for shock. So that's going to be your soft tissue stuff, whether it's opened or closed. And if it's open, there's probably going to be more wound care, bandaging and such going on than if it's closed. If it's closed, it's going to be more identifying, but I don't know that you'll be doing all of that much with the wound care type of stuff. So should be not terribly difficult. So let's move into the burn section now. How many different ways can you be burned?
Four.
4?
Yes.
What are they?
I was thinking of the CBRN.
You were thinking of what?
What is that? The acronym or the ACVR, the chemical biological rate? That's for like hazmat. Never mind.
Yeah, that's hazmat. Give it a few more weeks. We'll be there.
Isn't there? There's chemical, steam, thermal, and electric, maybe.
Okay, there's chemical burns. There's thermal burns, which are the ones we're most familiar with.
And radiation.
Radiation, electrical. I like it. So those are the ones that we'll be looking at and talking about. So typically, most of our cases, we're going to talk about thermal burns. This is going to be from heat, from flames. So these are the folks that are getting burned by fires. So, which is going to be probably the bulk of the burns that you would deal with, people that touched something hot or had something spilled on them that was hot. And then, or if they were in a fire, they had the flames or the heat that's burned the tissue. So the thermal burns is probably going to be the one that you see most often. Electrical burns are not out of the realm of possibility. People that are struck by lightning are going to have those injuries. People that are playing with high voltage electricity improperly, and the electricity lets them know that. So those burns are going to be present. If there's enough energy, like with a lightning strike, typically there's going to be an entry point and an exit point, and a very traumatic thing in the middle. So you'll actually see some injury sites where the energy entered the body and most likely exited the body. In a lot of cases, elbows, knees, the bottoms of their feet, places like that where that energy blows out of their body in search of ground. So in that case, you're gonna have some wound care associated with those things. You're gonna have some wound care associated with the thermal burns in those different layers of the skin, different degrees of the burn. And then if we're dealing with radiation and chemical burns, it does to a point get into hazmat some, because we need to make sure that the radiation is gone and that the chemicals have been neutralized and removed from the patient, so they need to be decontaminated, and that's gonna cause us a little bit of headache and grief in the initial stages to make sure all that stuff gets taken care of. Once we have all that, we can start working on these patients. So what is our concern with burns as far as our patient management is
Infection
Heat
and
loss.
fluid loss.
okay?
Fluid and heat.
Heat loss.
And fluid loss.
All right, so heat loss, fluid loss, infection. I've heard those three, and those are three good ones. What else?
Pain.
Pain. And there's one more that we need to talk about.
The body system that is affecting?
No.
No. Oh, the airway.
We'll get to the airway in a second, but so we've got heat loss, fluid loss, pain, what was the other one?
Infection.
Infection. And then we need to be aware that there may be edema.
Oh.
Okay, so that's going to be the edema is going to be an effect that is because of the fluid loss. So that's going to be one of those reaction type things from the body, which all is going to affect the airway. So with burn patients, just like everybody else, we want to check the airway first to make sure they have one. We want to investigate this airway to see if it was burned, if they inhaled hot gases, if there's smoke inhalation, if there is any trauma in that airway from the heat or from the fire or from the chemicals, whatever the burn was caused by. Then we want to investigate all of that for airway management. So it's going to be a little more in-depth airway management than a lot of your other patients, because we're going to be looking at some things in there. So you got to get in there and look in their mouths. If they're conscious, they need to open it up so you can see. And if they're not, then you need to open it up so you can see and make a determination. Is there any soot on their face, around their nose, in their mouth? Is there any burned tissue in their mouth? Do you see any trauma in there? Do you see any swelling in there? That type of stuff. So you want to look at those types of things to investigate the potential for airway compromise. And if you have some of that stuff burned tissue inside the mouth or throat, if you've got some, all their hair is singed on their face, eyebrows, nose hairs, those types of things, you can expect that edema is going to be coming. So that whole larynx and upper airway is going to start swelling. So this may be a good time, if you're able to manage that airway and get something more aggressive in there. It'd be a good time to think about it.
Now, Cliff, what about someone who drinks like a caustic substance, like a liquid caustic, and they swallow it like gasoline or something like that? And I've heard that will pretty much do the same thing.
It will.
Burn all that.
And what they'll tell you is they don't want you to make them vomit and bring it back up again and burn it again. So once they've swallowed something caustic, it's probably going to stay down and stay in. That's going to be a med control / poison control consult, I would suggest for you. But if there's some neutralizing things that you can also get down into their system and stomach to deal with that. But it's not going to be one of those things that they're going to want you to make them vomit up. Maybe do some. They may do some GI suctioning to get it out if they can keep it in the tubes and all, but it's not going to be an induced vomiting type of situation. But those chemicals can cause burns with all of that tissue. So again, regardless of how the burn was caused, our airway management needs to be more in-depth investigated and more maybe proactive and aggressive.
Okay.
So with the burn patients, we need to do a couple things. One is we need to determine how burned they are, and we do that by coming up with a percentage of their body surface area that's affected. Your book is you probably had the rule of nines in your EMT class, and you'll see those again here in your charts. They have an adult version, and they have a couple of different pediatric versions. So we're kind of more familiar with the adult version, and it's really more simple than the child versions, because oddly enough, in the rule of nines, they don't always use nines. So if you're not familiar with those, you should take a look at how that pans out in those charts. And then this book gives you some some pictures here: 3521, 3522, 3523. Those are all pictures of the different levels of different degrees of burns. So everything from a superficial first degree burn is more like a sunburn. The second degree burns, partial thickness, you'll start to see some blistering of the skin. Maybe you'll see the skin start to peel off a little. And then in the third degree burns, full thickness, you're going to start to see some charring, and that tissue is really going to become dead at that point. So different ways for us to handle these. They go the first degree burns, the superficial burns. You can run cool water on them and cool them down that way, and then you can dry them off and deal with the pain management side of it. So second degree burns, the partial thickness, you're going to start to see when you start to get the skin blistering and peeling, that sort of thing. Those are going to be more painful, and that's where the infection is starting to become an issue. And then the full thickness burns, the infection is going to be a big time issue, although you may find that the full thickness burns are not quite as painful as the so in reality, the second degree burns may be the most painful, whereas the third degree burns may not be as painful because they burn so much that they've burned the nerves, so they don't they're not getting those pain signals. So although these folks are more severe, they may actually not be in as much pain. So infection is the biggest concern with the full thickness 3rd degree. And the way that we do wound care with them is sterile, dry dressings. Okay, so wet dressings in the lower levels, but in the full thickness, it's going to be sterile, dry dressings.
Now with the full thickness burns, I get that they're really not gonna have that pain sensation.
Mm-hmm.
What when we be more concerned with the fluid shift?
Yeah, you're going to get that. So, and we're going to talk about fluid here in just a minute for the burns. But before we get to that, the other issue with the burns is going to be carbon monoxide. So if these folks are in a fire, if they're in smoke, and they're getting burned, if you have the ability to monitor carbon monoxide, that's a special feature that you had to buy and put on your cardiac monitor. So if you have it, fine. If you don't, okay. But definitely you want to, you know, put these folks on some oxygen, measure your SpO2s and your capnography. But if you can and have the ability to measure the carbon monoxide with your little Massimo rainbow thing, then by all means do it, because they're probably subject to the carbon monoxide issue as well. All right, so Chris brought it up. Let's talk about fluid shift. What's happening with all your fluid when the skin's burned?
It's dried up.
All right.
The body is compensating.
So we're using our skin as kind of a outer layer of protection and a defense mechanism. So now we've damaged that outer layer, so we don't have the protection or the defense mechanism anymore. So from a protection standpoint, that's where the infections come from, and then from the other standpoint of our integrity of that outer layer, it's gone. So our ability to regulate heat goes away, and then we have the fluid issue. So when the skin gets damaged, some of the fluid is gone, we lose it. Other fluid is shifting to the traumatic areas. So that's where some of that swelling comes into play. And then the next thing you know, we've got things that are all out of balance. So there's a fluid formula for burn patients. It's called the Parkland formula. It used to be much more simple than it is now. They've actually made it more complicated now, because instead of just being a set formula, it's now a range, which I think just makes things more complicated. So the way the formula works is it is the percentage of body surface area burned times their body weight in kilograms. And the old formula used to say times 4 mLs. And now the new formula says 2 to 4 mLs. So they give you a range. If you know the 4 mLs, if you've ever been familiar with Parkland formula before and you knew it as 4 mLs, what they did now was give you the option to cut it in half and work up to that. But you know, if you're new to Parkland formula and you didn't know anything about it before, what they're telling you now is 2 to 4 mLs times the body weight in kilograms times the percentage of body surface area burned. That is the amount of fluid that you should administer to these patients in the first 24 hours after the burn. And the way it works is half of that amount is going to be given over 8 hours, and then the other half is going to be given over the next 16. Does everybody understand that?
Yeah.
Yep.
Okay. And the preferred fluid is going to be lactated ringers. So if you have lactated ringers, now would be the time to use it. If you don't have ringers, you're only carrying saline, okay, but then use the saline, but they would rather you use lactated ringers here. All right. So put that in your mind. If you're dealing with burn patients, you should be dealing with ringers. And then you need to know the Parkland formula. So 2 to 4 mLs times your body weight in kilograms times the percent burned, partial burn, partial thickness or full thickness. They don't use the lactated ringers and Parkland formula on first degree burns. So this is only going to be second and third degree, okay?
Well, there wouldn't be any fluid loss on the first degree burns.
No, there shouldn't be. That's pretty much just going to be damage to the skin's outer layers and pain with the first degree burns. That's going to be essentially like sunburn. So, but the second and third degrees is where this formula is going to come into play because you're going to have that more severe damage and that fluid loss. So let's do a little exercise here with this formula. You guys are going to see this for a little bit in the next few weeks, but let's do a little exercise. So I'll give you a body weight and a percentage of burned areas, and then you guys can calculate and we'll figure this out. So let's say your patient weighs about 180 pounds, and the body surface area that burned is 30%.
How many milliliters do you want us to use? 2 or 4?
That's going to be up to you. That's the complicated part about this thing. Like I said, originally when this formula come out, it was 4. And then in the last couple of years, the last couple of versions of the textbook, they've switched to this 2 to 4 range. So again, that's going to be up to you.
What that means to me is I'm just going to use 3.
Good one. Good one.
Now in children, that is the range. 3 to 4 is the range in children. 2 to 4 in adults. 3 to 4 in children. I don't know why they can't just leave it at 4.
So my answer should end up in milliliters.
Your answer should end up in milliliters. Anybody want to share with what they have?
I'll try.
All right.
Well, I went with the 4 milliliters.
Okay.
So I converted 180 pounds divided by 2.2, and I rounded up to 82 kilograms.
82.
Times 30%, and I got 32. Excuse me. I got 82 kilograms times 4 milliliters, and I got 328.
Yep.
And multiply that by 30%, I got 9,840 milliliters.
Okay. So how much are you going to administer in the first 8 hours?
In the first 8 hours, I'm going to divide that by 2. 9,840 divided by 2, 4,920.
4,920 in the first 8 hours.
Yes,
so how
sir.
many is that? How many mLs per hour is that?
It is 82 milliliters.
82 milliliters per hour.
Uh-huh.
So when you're doing this calculation, it seems like a really big number. But when you break it down to where you're actually going to set your drip rate, 82 milliliters per hour is actually a fairly slow drip. Right?
Mm-hmm. Yes, sir.
I don't think that's right.
Wait a minute, what did we say the percentage was?
30.
30? I got 98.
That should be about 600 per hour.
Yeah, that's what I was thinking too. Is it should be higher than that. I was thinking 600 to 800. What was it? What was your number when you divided in half? Like 46 something, 47.
When I divided it in half,
Mm-hmm.
let me see. Calculator probably did 9,840 is what I had. Divide that by 2. I got 4,920.
Okay.
Divide that by 60, right? An hour.
No, it's 8 hours.
Oh, okay. My bad. That's why I went wrong.
So you got to divide that by
So 8 hours is 60 times 8, right? 480. So that's why I went wrong.
That'll give you the amount of milliliters per minute.
That would break it down per minute.
Yeah, if you just divide your 4,920 by 8, that'll give you the amount of milliliters per hour.
Per hour.
Okay, so 4,920 divided by 8.
Yes.
615. Okay.
There you go. So about 600 drops, 600 mLs per hour. And then if you break that down, if you want to go down to the minute, it's about 100 mLs per minute, right?
Well, 82. That's what I did at first. I did 6.
No, it's about 10.
10. About 10 mLs per minute.
Oh, okay.
So 10 mLs per minute is not a lot.
Mm-hmm.
Right?
Right.
Because we could run, we could run 400 or 500 in that 600. We could run that in about 10 or 15 minutes if we got a good size IV. So, so running 10 mLs per minute is not, it's not fast at all. So don't do this calculation and then think, well, I'm just going to run this thing wide open, because it certainly doesn't need to be. It's not a big, it starts out as a big number, but when we get down to actually measuring this stuff out, it's not going to be a very fast drip in some cases.
Hey, Cliff.
Yes.
So when y'all got to the 615 milliliters per hour, and you took that number and divided that by
60 minutes.
Okay. That's how you got the 10. All right, I see. 10.25. Okay.
Yep. You could have done it. You could have done it at that earlier step when you were going to multiply 60 minutes times your 8 hours. You would have gotten 480 minutes. You could have divided that 4,900 whatever by the 480. It would have come out to the same thing.
Yep. Okay. I see it now. Thank you.
Anybody else way off from that? So the total amount.
Extremely, but I suck at math.
Do what?
I said extremely, but I suck at math.
All right, well, let's fix you. You can't suck at math and do this. Where'd you go wrong?
I think I left out the whole step of converting it to mLs. I think is what I did.
Okay, so you had, what was your body weight? Were you around 80 kilograms?
Yeah, I went with 82. Yeah.
Okay. Did you go with 4?
Yeah. Times 30%, and I got 98.
You got what?
Let me double check, but I got 98.
So if you multiply 4 times 82 times 30, you should get about almost 10,000.
Well, I got like 98.4. What I got.
So he got his calculator set wrong because 9,840. He said 98.4.
Yeah, it should be.
Okay, I see what I did wrong.
Okay.
Okay.
Because you should be up around 10,000, almost 10,000. And then remember that number is for the total, for the whole first 24 hours. So we're gonna give half of it in the first 8 and the other half over 16. So that second half is gonna go, twice as slow as the first half.
So I would divide that by 8 hours or divide it by 2? Because if I gotta give it twice, wouldn't I divide by 2?
You would divide that number by 2, and then that lets you know what you're given the first 8 hours and then what you're given the second 16 hours. So that dividing it in 2 actually turns it into 2 doses. 1 dose to be administered over 8 hours, the next dose to be administered over 16 hours. So we won't have to worry about the second 16 because we shouldn't have them for 8 hours, right?
Right.
Right. We're just going to calculate this and get it started. Most of this calculation stuff is for documentation purposes because we're never going to see this much fluid administered over time because we're just not going to have them for that long of a time period.
All right, when I divided it by 2, I got 4,920, and then I divided that by 8, and I got 615.
Yeah.
Right.
So that's what you would administer in the first 8 hours.
Got it. All right, clear as mud.
Yeah, the 4,928 or whatever it was. That's how much they're going to get over 8 hours. And so when you divide it down into 8, that 600 and some, that's how much per hour they're going to get. So it's pretty slow. This is a pretty slow drip. Now just remember, the bigger the person and the more they're burned, the more fluid you're going to get into. You could get into amounts that are up like 20,000. You could see some 20 to 30,000 mLs worth of fluid for that first 24-hour period. So that, like I said, it looks like a big number, but over that much time, it's a fairly manageable drip. All right, so people typically can get, sometimes people can get burned to the point that we need to make a transport decision on these folks about where we're sending them. And if they're burned severe enough or in the right places, we need to think about getting them to a burn center. Okay, so just like criteria for a trauma center, we have criteria for a burn center for these folks. Anybody familiar with what some burn center criteria would be?
The percentage of burn.
How much?
You mean how much did they determine that they go to a facility?
Yes.
Ah.
Isn't it something like more than half the body percentage? And then if it's a airway or facial burn?
Okay, I'll go with the airway thing. Airway and facial burns, they get a trauma. They get to go to a burn center.
More than 80% of their body, I think.
No. The number's actually quite low.
Is it with fullness, full thickness 10%, greater than 10%, and partial thickness greater than 30%?
Full thickness, any percentage.
Oh.
If they have any percentage full thickness burns, they should be going to a burn center. Partial thickness burns greater than 10%. Burns to their hands, feet, face, genitals, or other major points. If they have chemical burns, electrical burns, including lightning strikes, or if the patient has pre-existing conditions that these burns would complicate. Those are some things that you can justify sending your patients from the field straight to a burn center. Okay, so burned airways, burns on the hands, feet, face, genitals, or other major points. I'm not sure what other major points there are. Any full thickness burns at all. Partial thickness burns, so that would be second degree, greater than 10%. And then chemical burns, electrical burns, including lightning, and patients with pre-existing medical conditions that the burns will complicate.
Cliff, where do you see that at in the book?
Huh?
Where you see that at?
Do you have a table 35-7?
Oh, I'm on 35.5 and 4. 35.7. 7. Ah, okay, I see here.
All right, you got it?
Mm-hmm.
Yep.
Now for that, The only burn center around that I really know of is Chapel Hill. Would we like
Yes,
request a helicopter to Chapel Hill or something?
absolutely. There are some other burn centers, though. I will tell you this: Norfolk has a burn center.
Ah, I didn't know that.
It's less renowned than Chapel Hill, and also Greenville is starting to have some burn treatment capabilities. Um, Although it's much more uh, inconsistent and not standard. So they're starting to work on getting some doctors that can handle these things. But yes, the for this area, the probably the number one choice would be Chapel Hill. So yes, that's what you would do. You would request a helicopter that can take this burn patient to Chapel Hill.
Gotcha.
I've taken some ground transports to Chapel Hill for burns. I can tell you that sucks. It's a long ride, so it's not fun. But yeah, these folks need to go. So get a helicopter. Let them go. They can take them to Norfolk to that burn center, but it's not as I don't think it's as capable. And the one in Chapel Hill is top of the line. So there's a picture 35-29. That's going to give you some exit wounds from electrical burns. So you can see you can see those spots where the electricity went into the body, and that's where one's on looks like the forearm, one's on the hand. That's where the electricity blew out and exited. All right. So as far as burns go, treatment for burns, we're going to do wound care appropriately. So you can flush first degree burns with cool water. No water on third degree burns. That's going to be dry, sterile dressings. And then second degree burns, that's going to be a blistering, skin peeling type of thing. So still stop the burn. We're gonna wet that down and stop it, and then cover it for infection control. If you're dealing with fingers and toes, you want to put gauze in between them, between each fingers and each two toes, so that the skins aren't touching each other. Because as they sit there touching each other, they may stick together and actually rip apart later when they're trying to work with it. So if you have fingers and toes, that you need to keep those separated. So make sure you're putting 2x2s or 4x4s in between the fingers and toes, kind of like when they go get a pedicure or something. So if you've ever had a pedicure, you know what I'm talking about.
You mean you don't go get pedicures, Cliff?
Not yet. I haven't started, no.
So I say you sound pretty knowledgeable about it.
Yeah, I'm pretty knowledgeable about a lot of things. All right. So the chapter 36, if you guys don't have any more burn questions, we're gonna do some lab stuff with that this week. So we'll talk some more about it, work with that formula some more, that sort of thing. Chapter 36 is the musculoskeletal injuries. So this is bones and muscles. Just so you guys know, there's 206 bones in the body. There's 700 skeletal muscles. So if y'all want to start going around, we'll start with the 206 bones, and you guys can identify them, name them, and then we'll go to the 700 muscles. Mark, you want to go first?
Yeah, don't worry. I'll just get them all.
Oh man. All right. So it would behoove you to have some familiarity with the bigger ones, the more prominent ones, the more likely we're going to deal with ones. A lot of these ligaments and tendons and muscles you may not know the names of because we don't really have anything to do with them. But the muscles that, we're doing IM injections in, or, the prominent muscles in the body, they may, you probably want to know those. So work on your A&P if you're not up on it real well. All right. So again, we have bones, ligaments attach bone to bone, and then tendons attach muscle to bone. So that's how those pieces work. So if you're having trouble differentiating those, probably work on your A&P a little bit. Cartilage is in between the bones and some of the joints, especially the knees. So that's why everybody has knee trouble. That cartilage wears out. Then bone is rubbing on bone. They have a lot of pain. So then they get knee replacements. Those types of things. All right. So in the traumatic injury world, musculoskeletal injuries, the soft tissue injuries that we just talked about, the burns that we just talked about, and then these musculoskeletal injuries we're going to talk about, that is where that mnemonic DCAP BTLS comes from. And that is all of the things that we're looking for in these types of situations and injuries. So, so the DCAP BTLS, when we're doing our trauma assessment, those are the things we're looking for. And these are the types of injuries that would give us those things. So soft tissue injuries, burns, musculoskeletal injuries, that's where it all comes together. So everybody knows what DCAP BTLS stands for?
Yes.
Yes. Go ahead then. Do it. What's it stand for?
Are you talking to me?
Yeah, you said yes.
I did. I know what it stands for.
Okay,
All
well,
right,
let's hear it.
DCAP BTLS. The D stands for deformity.
Mm-hmm.
The C, contusions.
Yep.
A, DCAP, DCA, abrasions.
Yep.
P, punctures.
Yep.
B, burns.
Yes.
DCAP, BTL. T for tenderness.
Yes.
BTL. Lacerations.
Yes.
And swelling.
Swelling. There you go. So as you can see, all of those are appropriate for these three types of injury areas we were discussing. So that's your trauma assessment mnemonic that you're going to be using to find injuries as you're assessing these patients. So the big thing with musculoskeletal injuries in the extremities, we are looking at broken bones. We may be looking at dislocated bones out of joints, things like that. So in most cases, the treatment for that, we're going to be looking at stabilizing and splinting those limbs. And the most important thing that we're going to be looking for in these injuries is the distal pulses, motor function, and sensory function. So make sure when you guys are dealing with injuries to extremities that you are checking before and after. You're checking for distal pulses, motor function, sensory function. Make sure it's there before you start any stabilizing. And then if you're going to stabilize and splint, make sure it's there when you're done. So that you can maintain circulation and function. With the bones, bones break. We have two types of breaks that we need to deal with. We have open fractures and closed fractures. So splinting open and closed fractures is going to be a little bit different. So with the closed, we just need to keep things in alignment and check for the distal pulses, motor and sensory functions. With the open, we're going to have to deal with the open part of the injury. So that means that the bone has broken the skin. And so we have open skin now, which means we're probably going to have some bleeding to some extent. And we're going to have the susceptibility of infection. So it complicates things just a little bit. So you'll see as you go through the book, they're going to give you ways to immobilize the arms, splinting, creating slings, those types of things with the legs, splinting in various forms, rigid splints, traction splints. They're showing you in here some pneumatic anti-shock garments, the mask trousers. Nobody has those on the ambulances anymore, but they have not been removed from the curriculum yet, so they're still here. But we're not even going to show you those in the lab because nobody even has them. They've got a couple different kinds of traction splints. Remember, traction splints can only be used on what type of injury?
Closed femur fracture.
Closed femur fractures. That's your traction splints. We don't pull traction on open femur fractures. What do we do with open femur fractures?
Stabilize it.
Yes. You can stabilize it. You can splint it.
But don't put it back.
You can do wound care to the open part, but do not pull traction. Try to poke it back in. Any of that stuff. All right. Sprains and strains. How do we treat those?
Elevation and ice packs.
There you go. Remember the Rice formula?
Yeah. Rest, ice, compress, and elevate.
Yeah. Rest, ice, compress, elevate. So it's still valid for sprains and strains. Dislocations. What do you want to do for those?
Stabilize.
Okay. What else?
Splint.
What else?
Elevate.
What else?
Don't try and put it back into place.
What else?
Rapid transport.
Check for
Pulse, motor, sensory.
Before and after. That's right.
good grief, people. Automatic failures, I'm telling you, on these skills things,
Oh God.
automatic failures if you don't check distal pulses, motor function, sensory function, before and after on splinting, stabilizing, dislocations, all of those things. All right. Any questions on this stuff?
No, sir.
So the skills lab this week, this is what we're going to be doing. We're going to be doing the splinting, the immobilizing. We'll be talking about the burns and working on the burns, and then the wound care for the soft tissue injuries. Everybody good with that?
Yes,
Yeah.
sir.
All
Yes,
right.
sir.
Sir.
Anybody have anything else before we go?
Nope.
All right.
No,
Well,
sir.
in that case, you guys have a good night, and we will see you in the labs.
All right, you too, Cliff.
All right. Take care.